So I'm going to talk about AV nodal reentry tachycardia, which is a type of SVT. So this means that the reentrant pathway is actually in the AV node itself, unlike AVRT, which has its own accessory pathway. So in a normal AV node, signals will travel down the fast pathway down to the ventricles, and it will come back up the slow pathway and block any signals that are coming down this way. So some key features about each type of pathway. The fast pathway has a longer refractory period. So the refractory period is the time it takes for another stimulus to come along and trigger a response. So no stimuli can actually be triggered before that time. So in the fast pathway, it's longer. So it takes a longer amount of time for the next stimulus to come along. In the slow pathway, the refractory period is quite fast. So once this is triggered, another one can be triggered pretty much straight away. Whereas the fast pathway, you have to wait a bit longer before it lets you have another signal. So what happens in AVNRT is, let's just say we have a premature atrial contraction that comes along. So what's going to happen is, normally with fire, it'll go down the fast pathway and block that signal. Now this has to repolarize, and that takes a long time to happen because of that long refractory period, so it's repolarizing here. A PAC comes along before it has a chance to fully repolarize, and the only option is to go down the slow pathway. So this PAC travels down the slow pathway, and on its way back up, it still travels back up the fast pathway now. So this is already fully repolarized, and it has the opportunity to send a signal in the opposite direction. And what will happen is this has fully depolarized here, so it has the opportunity to trigger it again. So just to go over it again, the PAC goes down the slow pathway and then back up the fast pathway, and then continues to go back down again and back up. So we get this reentrance loop that is really difficult to get back out of. So in patients that have this, they're going to feel really dizzy. They might have some blurred vision as well, might have some nausea, and mainly they're going to have a really fast heart rate because this is happening and just keeps triggering that heart rate to be faster and faster and faster. So the way that we fix this, we have some certain drugs, and most commonly we use vagal stimulation. And the aim of this is to try and trigger the vagus nerve to slow down the heartbeat, slow this conduction down so the AV node has a chance to finish that pathway so it can go back down the fast pathway instead of the slow pathway again. So this is AVRT, which is AV reentrant tachycardia. This is any SVT that doesn't use the AV node for its reentrance pathway. So a common one of these is Wolff-Parkinson-White syndrome. So what that is the heart has actually got an accessory pathway from the atrium to the ventricles, and it causes this loop sometimes, and people get stuck in SVT this way. So this is the accessory pathway here. So what happens is that will depolarize, causing the ventricles to contract. And when they depolarize, it will actually travel back up this loop and travel back down and up and down again, re-entering over and over and over again. I'm going to talk about what's happening in SVTs and why we see these kinds of symptoms in people. So an SVT will trigger a rate of around 150 to 250 beats per minute. So this is very fast. So this fast rate obviously results in people feeling those palpitations. It decreases that filling time in the ventricles and in the atria, and we lose that atrial kick as well. So when we have a decreased filling time, this means less blood is pumping out, which means we get a decrease in that cardiac output. Now, when we have a decrease in cardiac output, this leads to decreased blood pressure and hypotension, and that's how we can see signs of dizziness and fatigue and even syncope. When we have not enough blood going around, we need more oxygen, because no blood going around means a decreased oxygen level, so we're going to increase our rest rate, and we're going to be consuming more oxygen because of this fast rate as well. Decreased cardiac pressure will lead to decreased coronary perfusion, and we might see patients actually experiencing angina or chest pain in this. Now, because of this, in our ECG, we might even see some ECG ischemic changes. 5-step method for an SVT and what we'd expect to see. So, regularity, it will be regular because our R-to-R intervals will be constant. Rates will be, this should be 150 to 250. Atrial and ventricular rates will also be exactly the same. Our P waves. So P waves, there will be P waves because it is an atrial rhythm. So they will be before each QRS complex. However, because the rate is going to be so fast, we might not be able to see them. So we'll say they're hidden in the QRS complex. So the way we can tell if it is actually an SVT or not is because of our QRS complex, which will be less than 1.2 seconds. So if we have a rhythm that's really fast, but we can't see P waves, we know it's atrial because the QRS complex is normal. So the PR interval, we might not be able to measure it because we might not always be able to see a P wave, but it should be normal. It may actually be less than 0.12 seconds, but as long as it's not past 0.2 seconds, it should be okay. Them here. So the first thing we do is look at the regularity. So here we can see it's very regular. The rate, so let's just find one that falls on something. Okay, let's just take this one here. So 300, 150, so it's somewhere between 300 and 150. Let's just say it's 160 beats per minute to 170. So straight away we can see this is a form of tachycardia. Then I'm going to look for a P wave. So it seems that the P wave is quite difficult to see, but it's either, it might be this here or somewhere here, but there definitely is an atrial rhythm because our QRS complex is narrow. The PR interval is quite hard to determine, but we can say it's a normal rate and consistent because these all look the same. Again, the next step would be QRS, which we already talked about. It's narrow, less than 0.12 seconds. If this is an inverted T wave here, this might be signs of ischemic changes as well. So our final interpretation of this rhythm, because it's so fast, it has a narrow QRS complex, and there looks like there might be presence of a P wave. It's going to be a SVT or a narrow complex SVT because the complex is narrow at a rate of 170 beats per minute. I thought I would put in this ECG strip here because of the wide QRS here. So let me just talk through it quickly. So using our 5-step method, the regularity, this looks very regular. The rate, I'm going to use the bottom one here, so this one falls on top of it here, so 300, 150, let's just say it's a rhythm of 150 beats per minute. So P wave, this is just my interpretation, I might be wrong here, but I'm thinking that this is our P wave here, and it's an RSR complex because I don't see any negative deflections here for a QRS complex. So P, RSR, and this is our T wave, and then here's another P wave here. So our P waves seem to be upright, normal, rounded, so it is a atrial rhythm. Our PR interval looks to be at a normal length, and they are continuous across the board here. The QRS complex, so QRS complex is actually wide and bizarre here, which is something you wouldn't really expect for a rhythm like this, because it seems like the P wave is precipitating the ventricular rate. So what this tells me is this patient here might have some sort of ventricular damage, or hypertrophy or some sort of scarring to make this QRS complex wide and bizarre. This might also be leading into ventricular tachycardia as well, where we do see that wide QRS complex. So my interpretation of this rhythm is this is a broad complex SVT because the rate is very fast. We do have a presence of a P wave here, but it's broad complex because we have the QRS complex greater than 0.12 seconds. So my final interpretation is a broad complex SVT at a rate of 150 beats per minute.